Afternoon, uh, all our members of Cardiological Society of India, and also all the doctors who have managed some time of their busy schedule to join the first of this lipid webinar 2022. And I have the pleasure to invite the chairperson, our president of CSI, Professor P.S. Banerjee, and Dr. Nitin Kabra, who is the convener of the CSI Lipid Council, to chair this webinar and set the proceedings on. So, Dr. Banerjee and Dr. Kabra, please.
Thank you, Devabruto, and good evening to everybody. And you all know this is a very, very important webinar on lipidology, and nobody else than Dr. Sahni, who has dedicated his major part of the career on lipidology. And I hope that the audience who have joined today will be benefited by his lecture. And you all know that the lipidology is a very important part of our clinical practice, because the prevention of atherosclerotic cardiovascular disease is all depending upon the control of the lipids level in the blood, mostly the LDL level. And we all know that this is the single most important lipid particle which is closely associated with the atherosclerotic cardiovascular disease. And there is an ongoing change of the plan of management of the lipid disorders with newer invention of the drugs, newly added drug like bempedoic acid, which has also come into the market in India and is available for management, particularly who was statin intolerant or who shows side effects to the statin, particularly musculoskeletal disorder. And we all know this bempedoic acid is also a good molecule which has a different mode of action, although it is a ACL inhibitor, but it does not act at the muscle level, only liver. That is why devoid of any muscular side effect. And this can be added as an add-on therapy on low dose of statin along with the ezetimibe, or it can add along with ezetimibe and this molecule, new molecule. So with that, I will now request Dr. Sahni to start his talk on the management of lipids as it stands today. Thank you. Over to Dr. Sahni.
Thank you, sir. Thank you, Dr. Banerjee, Dr. Devabruto Roy, Dr. Nitin, Dr. Ashwini, Dr. Preeti Mistry. And good afternoon, dear colleagues from all over the country. And first of all, I'm thankful to CSI for giving me this opportunity to discuss in the first module about the management of dyslipidemia and abdominal lipid profiles in patients with Indian phenotypes. And I'm also thankful to the Alembic for their support for this education. So let me start my talk with so today I will be discussing about from the Indian phenotype point of view and our experience, how we are managing lipids today in India, and are we different from rest of the world or not. So these are the disclosures and conflict of interest of mine. And as we all know that the cardiovascular disease is one of the most common cause of mortality in our country. Approximately 25 to 30% of the people that die because of cardiovascular disease, mainly because of coronary artery disease and stroke, as against 40% the data which has been published in Lancet globally. If you look into the different regions of the disease and the prevalence of high cholesterol in different parts of the country, what we found the northern part of the country, particularly Punjab and Haryana, and in the southern Kerala, Tamil Nadu, and to some extent Maharashtra, has the highest incidence of coronary artery disease. Whereas the stroke has been found to be much more common in eastern part of the country, probably maybe because of high incidence of hypertension. Whereas the cholesterol levels are almost similar to that of coronary artery disease, more in northern part and southern part of the country. Now, as we all aware of the fact that we get disease almost 10 years earlier than the Western population, and it is been explained by probably higher risk factors of atherosclerotic cardiovascular disease like diabetes and the hypertension. And also, we have now learned that the genetic factors are also playing a role, like metabolic syndrome and the familial hypercholesterolemia. And now we have a data from our country of lipoprotein little a is also much higher in our country compared to the Western part of the world, and which leads to ultimately higher mortality because of cardiovascular disease, a severe form of cardiovascular disease which we get. And among the risk factors, which we found that the most important risk factor is the dyslipidemia. The key factor is the LDL or non-HDL cholesterol, which enters into the formation of atheroma. Who pushes the LDL is diabetes, hypertension, stress, and smoking. So that is the name. And then when we look into the data of our country, epidemiology, thanks to Dr. Rajiv Gupta for his wonderful work which he did. And what we found that if we keep the cutoff of general population of LDL more than 100 milligram, then roughly 50% of male and female in our country are having that type of dyslipidemia. But since we have a atherogenic dyslipidemia, high triglyceride and low HDL, and we also look into the non-HDL, because in them we look into the non-HDL cholesterol, which is 30 milligram more than the LDL cholesterol. That means cutoff of more than 130 was found in almost 55% of the patient in our country. So this atherogenic dyslipidemia is a typical Indian phenotype, and high TG, low HDL, and small dense LDL particles. Prevalence in various studies in our country have shown is more than 40%, as against 20% from Western literature, which has come from the Euroca population in the UK and USA also. The ICMR study showed that the almost 79% patient in India are dyslipidemic, but mainly they were because of low HDL and high TG, but the cholesterol levels were not very high, but they were high, but not very high as we see in our population. So what we have learned that for the management of dyslipidemia, whether Indian phenotype or Western world almost remains same because we participated in most of the clinical trials. And what we have learned now is that there is a log linear relation between the unit change in LDL cholesterol. And there are three evidences which came: Mendelian randomized trial of more than 50 years, prospective cohort study of more than 12 years, and randomized clinical trial for primary secondary prevention for almost 5 years of data. And what we learned was the randomized clinical trial, on average, we could able to reduce LDL by 80 milligram, which resulted in reduction of cardiovascular events by 30 to 40% only. But when we look into the genetic study of Mendelian loss of function of FPCSK9, for example, the LDL reduction was only 40. Compared to the general population of USA of 120 LDL, in them there was 80 milligrams. So reduction was only by 40 milligrams, but it was there throughout the lifespan of a person, which has resulted in cardiovascular events by 80%, much more than 2 times what we saw in randomized clinical trial. So that by showing us that earlier the better is a concept which is very important. We should control lipids in very early stage of our life so that we reduce the lifetime risk of the cardiovascular events. And we have also learned that if you reduce cholesterol by almost 1 millimole, 39 milligram, there is a reduction of cardiovascular events significantly. And with that 2.5 decades of research on looking at the cholesterol with the maximum doses of statin to high dose of statin, 80 atorva, 40 rosuva, we came to level of less than 70, and we found lower is the better. And that became the capping of the statin therapy. So then we started looking into non-statin therapy, like the ezetimibe in improved trial and PCSK9 inhibitor. And a very interesting finding came that for each 1 millimole reduction of cholesterol, LDL cholesterol, that means 40 milligram, the reduction of cardiovascular events for both statin and non-statin was not different. It was similar, 21% reduction of cardiovascular events. So it shows that the LDL reduction was very important. Pleiotropic effects may be there, but LDL reduction is the most important part. So first study was the improved trial. As we know that this was an ACS population, more than 18,000 patients. Those baseline LDL was around 70 with high dose of statin, and we have brought them below 55 to 53 milligram using ezetimibe along with moderate to high dose of statin compared to placebo. And what we found, there was a reduction of cardiovascular events. And these events were much more pronounced in diabetic population compared to that of non-diabetic population. Is it that the cholesterol absorption from the diet is more in diabetic? There are some data to suggest some of that is not in favor. And there is no difference between vegetarian and non-vegetarian diet because the enterohepatic circulation, which is playing a role, that's why the absorption is restricted by the ezetimibe. The other drug is the PCSK9 inhibitor. You know that is injection twice a month, 140 milligrams subcutaneously. And we know that the LDL receptors on the hepatocytes, they help in reducing the LDL cholesterol by causing the LDL particles to come down by endocytosis and secrete it out. The PCSK9 protein present in hepatocytes causes the degradation of LDL receptors. And this monoclonal antibodies, PCSK9 inhibitor, evolocumab, which is available in our country, acts by inhibiting the action of the PCSK9 and thereby having more and more receptors on the surface to bring the LDL cholesterol down. And if you look at the magnitude of the LDL cholesterol reduction is around 50%, ApoB even by 50-55%. Other parameters also improve, but the lipoprotein little a showed 25 to 30% reduction, which was not seen with any of the drug like statin or HMI. Now, this is PCSK9 had been supported by two major trials. One was the chronic coronary syndrome 4-year trial in large number of patients, 27,000 patients, where those who are already on maximum dose of statin with or without HMI and LDL is more than 70, they were given injection evolocumab versus placebo. And what we saw that there was reduction of LDL below 30 milligram and reduction of primary endpoint, but there was not much of reduction of the mortality they could see in that 2.5 years. But what we saw, the curve started only widening after 1 year. This is the story of statin also. It takes at least 1 year for reduction of cardiovascular events. Same thing which we saw in PCSK9 inhibitor. And good news was that going down below up to 20 milligram, it was safe. And it showed a further reduction of cardiovascular events in this population. And you can see here the safety profile, no new onset of diabetes or cataract or the hemorrhagic stroke, nothing was seen in this. They were very well tolerated and so drug has been found to be very, very safe. And now only a few days ago, we got the result of 4-year, the extension study, which 5 years more was taken. And what we found, this study clearly shows as the study went on further with open label extension of the trial, there was reduction of cardiovascular death also. So this proves that these drugs are not only reducing events, but also reducing cardiovascular mortality. The other study was Odyssey, acute coronary syndrome, almost 19,000 patients, similar drug, but here the drug evolocumab was used and we found keeping it LDL below 40 and reduction of primary events after 1 year. And here the mortality benefits were also similar because they were all high-risk population. And so with this evidence coming from non-statin drug, we learned that if you go down further, there is a further benefit in reduction of the cardiovascular events, and lowest is best probably in such a high risk, very high risk, extremely high risk population. So this was a great learning. And because of this evidence coming from statin trial and non-statin trial, European Society of Guidelines, which are being commonly used globally by most of the people, including our country, we follow that. And the guideline came. And they said that for every patient of cardiovascular disease or any patient, general population should look into the risk factors. So they're classified into a very high risk population is the one who has got suffering from atherosclerotic cardiovascular disease. A new addition was added this time was that ASVD diagnosed on imaging like CT angiogram or ultrasound of the carotid Doppler study. If there are more than one vessel, more than 50% blocked, then also it is considered a very high risk population. These are two secondary. The primary one is a diabetic with target organ damage with multiple risk factors, duration of more than 20 years, CKD, GFR less than 30. And finally, the fifth group is the familial hypercholesterolemia with atherosclerotic cardiovascular disease. For them, they have suggested to keep the LDL below 55. And this was the European guideline, but the ACC said at that time 70. But recently, their update has come and they have also agreed for keeping it below 55. And the patient, those who are getting recurrent events within 2 years, those who have got polyvascular disease, recurrent events, and these are the patients where they have suggested to keep it below 40, maybe going up to 30, 20 will be also okay if you're using strong drug like PCSK9 inhibitor. The second group is the high-risk population, which is a commonest population in the country, which we see in clinical practice. And here they've shared that the diabetic patient without target organ damage or diabetic patient with single risk factor should keep their LDL below 70 milligram. I think the most of the diabetic population belongs to this group. And the second group is what they found LDL more than 190, single risk factor. And now they're saying blood pressure, which is a new thing which they have added. If any patient having hypertension stage 3 or a patient has got a hypertension with target organ damage with microalbuminuria, retinopathy. These are the group of population, they belong to a high risk, and one should keep 70 milligram, less than 70 as a target in hypertension patient also, just like diabetes. So this will be the future of management of dyslipidemia in risk factors population. Moderate CKD also less than 50%. Only moderate risk population are young diabetic patient, those who are less than 35 with short duration of diabetes, no risk factor, is a rare group. We are probably keeping below 100 may be good. For general population, they have suggested to keep it less than 100 milligram. 115 for US ESC, but for India, we found less than 100 is the good way to look into that. The other important area which I want to discuss for our country is that unfortunately, most of the even tertiary center in the hospital, they do not do lipid profile. If you look into the discharge slip of the patients coming with PCI or with managed with ACS, every investigation is there, but lipid profile is missing. There's some debate that they say that anyway, we are giving high dose of statin. What is the need of lipid? But no, that is wrong. So one thing we must learn that for lipid in ACS patient, along with the routine investigation, we should send with the very first sample lipid profile and LPA. This is what the recommendation has come, and we have no doubt that no more fasting is required. This is a big data which has come now, that from the large data which has come on more than 3 lakh population, that there's no difference between fasting and non-fasting in major lipids like the cholesterol, LDL, non-HDL, but some changes at the triglyceride level will be there. So patients, those who have got very high triglyceride, probably we ask them to go for fasting. Otherwise, any patient, child, elderly patient, diabetic patient, ACS, follow-up, statin, even non-HDL target can be easily calculated without any fasting state. So this is what we have learned out, that the patient of ACS should get a investigation of lipid profile as a part of the initial investigation, because it's got 2 important reasons. One, whether this high lipid in that patient is the cause of disease. Number 2, if the lipids are more than 110, 120 LDL, then starting alone statin of high dose may not be enough. You have to add HTMI from day 1, so that we reach the goal early. And in ACS patient, reaching goal early is always good to reduce the future cardiovascular events. So this is what the important message I want to say, that please do the lipid profile and try to adjust the doses on that. So the guideline has suggested at that time that step 1 to give high dose of statin, and if not reach the goal of 55, then use HTMI after 1.5 months, and then after another 1.5 months, if not reach the goal, then add PCSK9 inhibitor. Now, this approach has been recently challenged, and because we know that the high dose of statin only reduces LDL by 50%, and if you add HTMI, which is 65%, 85% if you add PCSK9 inhibitor. So recently, European Atherosclerosis Society Task Force and good meeting this year again in Milan on atherosclerosis, they have come to conclusion now that probably 3-step high-dose statin followed by HTMI and PCSK9 can be reduced to 2 steps in patients, those who come with acute coronary syndrome and they have, or any chronic coronary syndrome, and those who have got baseline LDL, statin naive LDL, more than 110 milligram. Because we know by giving high dose of statin, you'll only reduce by 50%. So if it is 120 LDL, we will only reach 60 milligram if we use alone statin. So we will wasting the time for 4 to 6 weeks. So add from the beginning, the HTMI. So early intensive combined lipid therapy is a way to go for such population, which is not a small population in our country, is also a very big population. That's what we have seen. So there is no new thing which has come now. And later on, we can add the bempedoic acid or PCSK9 inhibitor after doing subsequent lipid profile. This is what the study which we did in our country, and I presented this year in the meeting in 22nd May in this year only. This is a study which we did in our patient with coming with acute coronary syndrome, and we were looking at what should be the doses and how we are acting. And we did lipid profile at J0, 3, 7, 15, 28, and even 42. And our inference came from the study was that our response to the high dose of statin reaching goal to less than 55 was more than 85% could able to reach the goal of less than 55 at 4 weeks, as against the Western world of around 60%. And what another important finding which we found, we have 70% reduction of LDL as against 50% compared to the Western world. Probably we respond to statin better. And approximately 15% required only non-statin drug like the HTMI and now probably bempedoic acid, and PCSK9 fortunately, is a very, is an effective drug, no doubt, but it's a very costly drug. The requirement is very little in our country, but yes, 1 or 2% patient of FH, they need PCSK9 inhibitor to reach the goal. So that is what the data came from our side. As Professor Banerjee has just said about the bempedoic acid. So this new drug is now with us now. Inclusion is coming soon. And we know that, as you said, that the statin intolerant, unable to reach goal, FH population are the one. And this drug is a pro-drug, has to be metabolized to active drug in the by enzyme ACSVL1, which is fortunately not present in skeletal muscle. So we do not get the side effect of myalgia. This drug acts a step ahead of HMG-CoA by ACLY enzyme and reduces significantly the LDL levels. There are 4 phase 3 trials which have been published, and they have shown that if you use alone, bempedoic acid reduces by almost 25%, but if you use along with statin, almost 18%. And the studies have also combined the HMI with bempedoic acid, and alone they have shown that it reduces, a combination uses by 36% with statin and 45% with alone with HMI and bempedoic acid. So it's a very effective drug, no doubt in that. There are 2 news which important to learn from this study was that one was the good news that unlike statin, which causes hyperglycemia and new onset of diabetes, particularly Indian phenotype population, those who are having metabolic syndrome, their chance of developing new onset diabetes is very high with statin, depending upon the dose. But what we found with the bempedoic acid, it works on the other way around. It reduces the sugar levels, reduces HbA1c. So combining this with statin probably will nullify the side effect of the statin and may be a very useful drug for future to be used. The bad news is that it increases the uric acid, so we have to be a little careful for a patient with gout, and also there is some evidence of tendon rupture. So patient is suffering from tendinitis and all that, we have to be very careful. The clear outcome trial is going on. I think after a few months, we'll get the result of this. And this study is on more than 14,000 patients, statin intolerant patient, bempedoic acid is being used. I'm sure this will be a good study to learn the lesson from this. And so the summary of this is that there's a very effective drug, as I said, it's 25% reduction, statin naive, 18% on top of the action. And it also reduces HSCRP by 25%. And as I said, that improves the glycemia in most of the population. The second drug, which is approved by FDA already, that is like that is inclisiran, it inhibits the production of PCSK9 as against the receptor blocker with the PCSK9 inhibitor, and is a very durable drug and very potent drug. Reduces by 300 milligram twice a year doses, reduces LDL by 50%. Very safe, effective, well-tolerated drug. Dr. Kaushik Ray is working on this in Orient trial, and Orient 4 on the atherosclerotic cardiovascular disease endpoint study is still going on. I think we have to wait for 2 more years to get the final answer, but the drug is now being used for patients. Particularly, this will be a challenge to PCSK9 inhibitor because of compliance, because this works only for twice a year against 24 injection with PCSK9 inhibitor. And secondly, the UK has now given a clearance for the primary prevention patients to give as a working ligand and a vaccine. This drug can work once a year or so to keep the level of the society at a less than 100 or in patients. So coming to other area of our Indian phenotype is a high triglyceride, whether this causes cardiovascular disease or not. And the guidelines are very clear that if up to 500 milligram of triglyceride, probably there is no need of adding any fenofibrate, just intensifying the doses of statin and HMI is good enough. And this is the data which was published recently. It shows very nicely that in the society, in the European countries, 25% of patients, they are having high triglyceride level in spite of being on a target of LDL cholesterol. And we found in our studies that it is almost 40%, not 25%, because we have got much more metabolic or patient with atherogenic dyslipidemia. And the right up side, the graph shows clearly that as the triglyceride levels increase up to 450 milligram, there is an increase in cardiovascular events. And this is because of the presence of remnant cholesterol in the triglyceride. And the remnant cholesterols are basically the VLDL cholesterol, the IDL cholesterol, the small chylomicron cholesterol. And this high TG also reduces the size of LDL to small size. And all these factors, they ultimately enter into the intima and causes atherogenesis. And for that, patient with high triglycerides, more than 200, in spite of lifestyle modification, the recommendation is to calculate non-HDL rather than LDL. And unfortunately, in clinical practice, we fail to target non-HDL. We keep on looking at LDL. I've seen many patients of mine, though reached less than 55, but I found the non-HDL was almost, it should be 30 milligram more. It was 60 or 70 milligram more. So we should learn to add more statin or HMI or bempedoic acid to target the non-HDL cholesterol, which now has been described as 85 milligram for very high risk, the 100 milligram for high risk, and moderate risk less than 130 milligram. The remnant cholesterol is nothing but the cholesterol present in triglyceride, and this can be easily calculated. Triglyceride minus LDL cholesterol minus HDL cholesterol is remnant cholesterol, is 15 to 30 milligram. So this is what has been now suggested. And the HDL role has been played very low now, and nobody bothers about HDL at the moment. And this slide shows clearly the VLDL lipoprotein, which contains the blue color is the triglyceride, which do not cause atherosclerosis. The yellow part of the VLDL lipoprotein is the actually atherogenics, which contains the IDL and the VLDL lipoprotein, which enters into the atheroma formation to the macrophages to form the foam cell directly. They don't need oxidation as compared to LDL cholesterol, which needs oxidation before. So that shows that it is no more atherogenic and is important part of the atherogenesis. We cannot exclude triglyceride levels. And for that, the study came ultimately was by Dr. Cannon, by Dr. Deepak Bhatt on the REDUCE-IT trial. They look into the 19,000 patients for both primary and secondary prevention, patient with cardiovascular disease, patient with diabetes, and with multiple risk factors, having triglyceride more than 135, and giving them an EPA of 4 grams per day compared to placebo. And what we found that, again, you can see here, the curves start diverging only after 1 year. And that shows that the 25% reduction of cardiovascular events, secondary events were also reduced by almost 26%. And this study was almost similar to the JELLY study done at Japan on 18,000 patients, both primary and secondary population. But here, instead of 4 grams, they gave 2 grams of EPA because the Japanese, they eat a lot of fish. Their inherent EPA levels were high. So, and that shows that there was 20% reduction. So ultimately, they say that there was not much of reduction with triglyceride, but the EPA level was high. And that is the problem mechanism of causing reduction of events in such population with high triglyceride. And this is the algorithm which we have learned now how to manage the high triglyceride in our country and everywhere. And this is what the up to 500 milligram, I think one should look for always non-HDL cholesterol, calculate non-HDL cholesterol. Lifestyle modification is very effective, very, very effective. Weight reduction, exercise, reducing alcohol, smoking, reducing vegetarian diet, everything takes care. And most important, the control of diabetes. Must control diabetes. That will itself will reduce the triglyceride by 100 milligram or more than that. And then they suggested to add a statin and HMI. And if you're not achieved the if you achieve the non-HDL cholesterol level by adding statin and HMI, then still triglycerides are about 200. Then they've suggested to add EPA. The role of fenofibrate is probably later than that. Maybe for primary prevention, we may play with that. But this is the group which is working to reduce the atherosclerosis. But the patient who has got triglyceride more than 500, in thousands, and we have seen recently one patient of 13,000 triglyceride. And what we found that group is now, we are not afraid of atherosclerosis because here it is the large chylomicron particles, they are playing a role. They do not cause atherosclerosis, but they plug the pancreatic vessel and cause pancreatitis. So this is a third important cause after alcohol and gallstone, the pancreatitis. And again, here the management is similar, lifestyle modification, which I've discussed, but here the fenofibrate plays a very important role. You have to give them fenofibrate, bring them below 500, the triglyceride, and then repeat the lipid profile, and then think about adding statin. And EPA also can be added in this group of population. But if the people have a triglyceride of 4,000, 5,000, most of them will not able to control this, even by adding even saroglitazole, which has now been DCJ has given approval for diabetic population, but now also for NASH population. And it's a good drug. It also reduces triglyceride. But those who are unable to reach, then now we have a drug called volnaceron. which is antisense nucleotide, which is not yet available in our country, but is under investigation in Europe, is very effective drug, reduces triglyceride by almost 80%. And now evenocumab was also there, which is but not available in our country. So this is how we should manage. And finally, coming to the last part of my talk is Indian phenotype, looking at the genetic factor that our country, we have genetic factor much higher than what we thought or we believed. This is our data, which was published also recently, and we're going to publish another article. We know that there are two varieties of FH of heterozygous and homozygous. The heterozygous are much more common, one in 250, high level of triglyceride, LDL cholesterol, generally more than 150 or 160. And causes premature atherosclerosis in fourth and fifth decade. Is very common problem, underdiagnosed and undertreated. Homozygous is fortunately rare, but they get disease in first or second decade only, and they have a very unfortunate follow-up. How to diagnose this condition, because the best gold standard is always to do a genetic study of the LDLR or ApoB or PCSK9 inhibitor, but but the availability of the genetic is not very common. So we started looking into phenotype diagnosis, and among the various methodologies like Simon Brumer, WHO, and MedPad, the Dutch Lipid Clinical Network seems to be the easiest, a simple way to diagnose FH in clinical practice. Only thing what you have to do is to look at the young coronary artery disease population, which is not very low in our country. More than 50% of the population in our country, they get young coronary artery disease, less than 55 male or less than 65 women. You get 2 points for that. You look into the family history of similar age group getting a similar type of disease, 1 point. But sometimes we have to spend time to get the family history, because many times stroke is not given by the patient's history. So we only look into heart attack or bypass or stenting, but also ask for stroke. And that also is a part of the family history. And thirdly, we look into the cholesterol level. If the levels are above 150, we get 1 point, but above 190, we get straight with 3 points. And then we also look into, in young population with very high cholesterol, when we are seriously looking for the FH, the arcus cornealis, which is more common in upper part of the cornea. We have to lift the upper eyelid to see that grayish deposit, which if you get that in young population, you get 4 points. So any point above 6 is called a potential FH, which has been validated with the DNA analysis, with the genetic scoring, and found to be almost similar. And we found that in our study, which I will discuss with you. So what the guidelines suggest, that any young coronary artery disease patient who has got less risk factors, but very high cholesterol level, always screen for FH or look for Dutch lipid clinical criteria and try to diagnose that. If the score is above 6, think that this is an FH patient and should be treated with the high dose of statin with or without HTMI, or maybe bempedoic acid to keep it below 55. But the treatment is not complete unless and until we have done the family cascade screening. That is the main message I want to say. The diagnosing only lipid is not important. If you pick up FH, you can save many people. So what is cascade screening is nothing but doing a non-fasting lipid profile for the family members, the children and the siblings. And if you look at the levels, if they're above 150 for children, above 160 for adult, think he's a carrier of the of FH in that population. So by diagnosing an FH, we do not identify a case, but a family at risk. In my experience, from each family, I used to get 2 more patients, those who are carrier, whom we have started them on now on statin and preventing future premature cardiovascular disease. Starting statin as early as 8 to 10 years will push the disease by 20 to 30 years. This is what we have learned. So it's very safe drug to be given to children also. This was our initial publication on 600 patients, where we found that 15% chances of having FH, a Dutch lipid clinical score of more than 6. And subsequently, we carried with our study further, and now is almost more than 1,200 patients. And what we find, it is almost touching 17%. So the definite group and probable group, you can see that 17% of them are suffering from familial hypercholesterolemia, which we are missing them, because one thing will be there, we'll treat them, we'll prevent many family members in family. So what we found, another interesting finding in our study was that in young coronary artery disease patient, we divided into 4 groups, definite group, probable group, both come under the potential. possible FH and no FH, but young coronary artery disease. And what we found, the associated risk factors like diabetes, smoking, hypertension, this was much less in definite and probable group, but more in possible and no FH group, whereas cholesterol levels were much higher in definite and probable group. So that shows that if any patient who comes to you with with coronary artery disease, young man or person, then if he has got high cholesterol, but without associated risk factor, always think he's suffering from FH. It is very rare to have a male person having no risk factors or no smoking or no diabetes, or women without diabetes getting a coronary artery disease in a young age. If it is there, think that it is nothing but FH and look at the cholesterol level, and that is very important. So this is the data from USA. They found 10% of patients from the Harvard Medical School data, and from Australian data came, there's around 14%. So ours is more than 15%, touching almost 70%. So the prevalence of FH is very high in our country. The second prevalence, which I found now very high in our country, is lipoprotein A. You know that this is LDL along with ApoA, which is a procoagulant factor, much more dangerous. And the recommendation of guidelines suggested that every person for first lipid profile once in lifetime should get his lipid profile, LPA level. And if you found there is an inadequate response to statin in a given patient, please look for LPA, probably because the LDL present in LPA is resistant to statin therapy. It do not come down very easily. So that is very important what we have learned. And the data is very clear now from the meta-analysis of clinical trial, Mendelian randomization, and genome study. The higher the level of the LPL, the higher is the incidence of cardiovascular disease. The cutoff is approximately 50 milligram now, as the guidelines suggested. And this is there was not much data whether if you reduce LPA, there will be reduction of cardiovascular events or not. So finally, from the 4-year trial, the data came, those who got baseline LPA more than 50 milligram compared to less than 50 milligram, the beneficial effect of the PCSK9 were very high. So thereby suggesting that LPA plays a very significant role in causing atherosclerosis. And this is the data from the UK Biobank, which have shown that the highest number of LPA in the world is in the Black population, followed by South Asian population where we belong to, and white population is much less in that. And those who got high level of LPA, the atherosclerosis was much higher, as you can see on the right side of this. So Indian population is very high compared to the rest of the world, almost double. And so finally, what we presented our data this time on LPA and the atherosclerotic beating also. And what just to give you a summary of more than 1,000 patients of atherosclerotic cardiovascular disease, we analyzed the LPA, and above 50 milligram was found much more in younger population than elderly population. And these levels were correlated with the severity of the disease. Those who got high LPA, the severity of disease was much higher by Jensen's score. And finally, my last slide is to discuss with you, is there any role of nutraceutical in the management of dyslipidemia? Yes, because we have a low-risk individual coming to you many times in the clinic between 20s and 30s or 30s, young boys or girls, they come to you that they have no risk factor, they have no family history, their LDL is 150 or 140 or 130, which is high than the normal general population. How to manage them? Shall we give them statin? We do not have any data on that. At the moment, only they say give statin to a person who's got a premature history of premature cardiovascular disease, who's got calcium score high, LDL is above 160, so or multiple risk factors like diabetes and hypertension, give even in young patients, start statin. But there are many young people, those who do not have any of these factors. They have only high LDL. If you're treating high blood pressure in young age, if you're treating diabetes in young age of 20 to 25, why are we not treating LDL at a young age of 20 to 25? That was the question. The answer is still not there. But what people have suggested now, they're probably in low risk individual with non-optimal lipid levels, moderate to mild to moderate dyslipidemia with low risk probably is one of the area where nutraceutical will also come. Although there is not much of a randomized clinical trial, very few, hardly any outcome trial, but randomized clinical trials of nutraceuticals are available. And now they have been using this drug along with statin intolerant patients with the ezetimibe and pemphigoic acid. There are 3 groups of drugs which have been investigated. Absorption inhibitor is the plant steroids, which reduces LDL on average by 10 to 12%. The LDL synthesis inhibitors are the red yeast rice and garlic. they are more powerful, almost 10 to 15 to 20%. And LDL excretion improvers are berberine, 15% reduction. So these are the group of drugs probably in young children can be given. They are safe drugs, although the red yeast rice works like HMG-CoA reduction, so may cause some myalgia, but it is still safer drug to be used. So there is a thought now to use this group of drug in such population. So finally, ladies and gentlemen, dear friends, to conclude my talk, I want to say that dyslipidemia is the most powerful risk factor. Prevalence of atherogenic dyslipidemia is very high in our country, and for that, non-HDL target should be done, which we often forget in clinical practice. And both of them, LDL and HDL, is very common, easy, non-fasting, simple tool to monitor dyslipidemia, supported by large clinical trial over 2 decades. Guidelines have suggested to keep it below 55, and there is evidence from small study that we tolerate statin better, and we respond to statin. Probably we are better responder to statin, but problem in our country is the adherence, which is at physician level and outside patient level, and maybe cost factor plays a role. Early use of combined lipid therapy, combination of high dose of statin and ezetimibe rather than high intensity statin alone will achieve the goal in most of the patients. FH is quite high in young MI in our country, grossly underdiagnosed. We should look for it, try to save a lot. We have got almost 50 lakh population in our country suffering from FH. High LPA is also more prevalent in our country and is associated with in younger population with severe disease. FH and LPA registry is going on at the moment, and we are in the phase of accumulating data of our own country to write the Indian guidelines. So finally, the slogan for management is earlier the better, lower the better, longer the better, and now together the better. Thank you very much for listening to me.
Thank you, Dr. Sani, for an excellent lecture on lipids. I think you have beautifully brought out the concept of cumulative exposure of LDL over one's lifetime as a risk factor for atherosclerotic cardiovascular disease. And you've also stressed on lower the better, because till now, for primary prevention, I think the suggestion for Indians, 100 should be the starting point. So LDL less than 100 should be the goal, and primary prevention LDL less than 100. That will go a long way in preventing the Indian CAD and this one. We've also stressed very much on the upfront combination therapy. Even only 15% of Indians may require that, because we respond better. And you have beautifully brought out the importance of triglycerides as a risk factor in atherosclerotic cardiovascular disease, especially in our population, and the importance of lipoprotein little as a risk factor for coronary artery disease in our population, South Asian population. And I think we do have a drug in the pipeline, and it's due for FDA approval in the US for the treatment of LPA. So besides the PCSK9 inhibitor, till now we used to have only like estrogens and those sort of things. But for niacin and all, which have not proven to be very good at the outcome preventions and that way. But probably the new drug which is approved by the FDA and all for the treatment of LPA, probably we may have a wonder drug. And one point which I would like to add is LPF more than 100 milligrams per deciliter probably should be taken as one of the very important risk factors for South Asian CAD. And thank you for the extensive review once again.
Yes, so we have a drug called pilacarsen, as you rightly said, is now already developed, not yet approved by FDA. And we are doing the Horizon trial at the moment with that drug in the country. So I think in future there will be a definite therapy for LPA.
I think for Indians, that's the need of the hour.
Yeah, that's right. You're right. But I think I always emphasize on FH, which unfortunately have been overlooked by most of our women colleagues. I've seen they don't look into that. So they just treated them as a simple variety of, hyperlipidemia rather than looking into FH part of the story, which is very, very important.
Yeah. And going by the series which you have, the incidence of 15 to 17%, probably I think all of us should be more aware of this, and probably looking into the next patient itself, we should be looking for that. And this.
Yeah, yes.
15 to 17% prevalence, I think, is too high probably for us.
Yeah.
We have to take it seriously.
Yeah.
Dr. Banerjee?
Yes, so I think Dr. Sani has given a wonderful deliberation of the talk. And I think, as he has said, that the level of consciousness or awareness about the dyslipidemia, particularly focusing on the familial hyperdyslipidemia, this is very important to prevent the heart attack in the young, because then we will really lose the workforce in our country. and lot of drugs are coming. So awareness is very important, like diabetes, hypertension, coronary artery disease. So dyslipidemia awareness is really very low, and that should be increased by conducting more and more this kind of webinars and how to prevent and detect the dyslipidemia at the early stage, and to prevent any further atherosclerotic cardiovascular disease, and improvement of the overall the population's health, as well as the economy of the family, as well as the country. So that's all from my side.
Thank you. Thank you, sir.
Dr.
I'd like to thank Dr. Devabrata and Dr. P.S. Banerjee their untiring efforts to make this webinar successful and to get the Lipid Council as a part of the sub-council of the CSI. So thank you, Dr. Devabrata and Dr. Banerjee.
Thank you.
Thank you, Dr. Sahni, sir. As usual, it has been an excellent deliberation from you. And I have two questions. First, in cases of non-STEMI PCI, do we need to give high-dose statin? And if we need to give high-dose statin, should we load the patient prior to PCI, or at the time of discharge, or just after PCI?
Yes, sir. I think good question. As we have seen when we were doing the data collection for the familial hypercholesterolemia, we came across that approximately 25 to 30% patients, those who come to us, are already on statin. I mean, either they are already on statin because of other chronic CAD or because they were diagnosed earlier. So it becomes sometimes difficult when diagnosing FH through Dutch lipid clinical criteria, because criteria says above 150 is statin naive patient. So how to know whether this is a patient's actual LDL cholesterol was there at that time? And most of them reports are not there. So there is a calculation factor now available, which is called adjustment factor. For example, for each statin, there is a calculation factor. For the 10 milligram of rosuvastatin patient is on, and if we found non-fasting lipid is around 120, then we have to multiply with 1.2, which is the adjustment factor, which comes to around 190 or so, something like that. So this becomes then how to manage the Dutch lipid clinical criteria. So coming personally to specifically to your question, in PCI population, yes, a significant number of patients are already on statin, then we have to reload them. This is the Armida trial came, and many other studies have favored that. You should reload them. But for 70% of the patients are not on statin. So anyway, we have to give them 80 milligram of atorva or 40 milligram of rosuva to this patient. And there was a very good paper just published recently, only a few months ago in JACC, where they look into the outcome of patient of PCI in over a follow-up period. And what they found, one of the important risk factors, you see what happened, the interventional cardiologists, they did their job well, but they forget to follow them up with the other risk factors. So diabetes, blood pressure was fairly well controlled. And what they found in that study, that majority of the patients, those who are on high dose statin, are ultimately moderate dose statin in follow-up. And the LDL level was never checked. It was always 80, 90 or so, and they came with recurrent events. So they found that it was not the type of stent or the under deployment of stent which has played a role. It was the LDL, which remained high in follow-up, which was ignored by interventional cardiologists. And that has resulted in restenosis of the stenting. So that's what the message is, that the follow-up of patient after PCI is very important. And looking into the guideline-directed goal of the risk factors is also very important, keeping BP 130, 80, and HbA1c around 7 to 7.5, but LDL below 55 is very important, which has been ignored and which results in higher risk. So that's what the message comes, that we should be careful with that.
Another interesting thing that I noted, you see, there has been a nutrition transition study in India spanning from, I think, from 1986 to 2011. The most interesting finding of the study is that irrespective of the socioeconomic status, in Indian diet, 86% is contributed by the carbohydrates, and only 6 to 8% comes from proteins and vegetables. So, do you think that on behalf of the society, we should take a serious look at the dietary behavior, especially when there has been a uniform distribution of carbohydrate, especially among the lower socioeconomic groups, through the public distribution system?
Yes, I think it's a very important and practical point. So the answer came from pure study, where we have learned now that the sugar or carbohydrate is much more dangerous than modest consumption of saturated fat in producing atherogenesis. Explanation is very simple. What they gave was that if you consume high fat diet, I mean saturated fat, which is approximately 10% is allowed, less than around 10%. If you take ghee, butter, or mutton or fish or whatever, I mean saturated fat, there will be increase in LDL cholesterol. But this LDL is large size particle. There will be also increase in HDL particle. So what happens? The ratio between LDL and HDL remains same. Now, if you look at the other side, if you consume, as you said rightly, the high carbohydrate diet, sweets, sandesh, all those the sweets, what we take a lot of in India, and so this increases triglyceride, and which causes reduction of HDL cholesterol. The LDL cholesterol do not increase because in vegetarian diet there is no LDL. So the ratio between LDL and HDL is disturbed because HDL has come down, and this LDL becomes smaller in size. So since the ratio changes and the size becomes smaller, it enters into the atheroma formation very well. So that's how they suggested now that they sweeten sugary beverages like Campas, Pepsi, all those and juices which are available now. They are much more dangerous in causing atherosclerosis than a small consumption of fat. But yes, we must learn that patients suffering from cardiovascular disease, patients suffering with diabetes or familial hypocholesterolemia, they should restrict the dietary cholesterol to some extent, no. But general public do not need any restriction of cholesterol. This is what the guidelines suggested now in 2015 American dietary guideline, that the cholesterol has been removed as an offending agent from the diet for general public, not for patients suffering from cardiovascular disease. That is true. But unfortunately, many people thought other way around, that it is not required in patients suffering from cardiovascular. So ultimately, one should learn the killer of human being is LDL or non-HDL. No doubt in that. But for a general public, since the absorption of cholesterol from the diet is only 20%, the 20% is contributed by diet in the serum cholesterol, 80% is manufactured by liver, which is entirely genetically determined. So for that reason, I think removing modest consumption of little butter or ghee or chapati with ghee and some chicken or mutton may be better, I will say, because in India it is goat. and goat meat is much better than the lamb meat. Yeah. And maybe it is better than even chicken, because chicken is broiler. It is not a pure meat. Mutton and goat meat is a pure meat. So that shows that the dietary myths are there in society. People say take a lot of milk. It is very nutritious. In fact, this is not a good fact. And you can take milk products like dahi or some curd and all those, a little bit of cheese and all that. But drinking a glass of milk in the morning, evening is not a good idea. Similarly, people used to say, don't take cashew. It has got cholesterol. In fact, it has got zero cholesterol. So concept has to come that anything comes from animal kingdom is non-vegetarian, milk, egg, and meats, and it will contain LDL because there is a liver sitting there. Plant kingdom, no liver, so no cholesterol.
It brings a very interesting debate to my mind. Yes. So this question is both for you and Dr. Kabra.
Yes, sir.
Would you recommend your patient having egg yolk if he has a high lipid level?
Generally in my practice, we ask them to take the egg white, and this has been going from our MBBS days. And the yolk is supposed to be rich in fat and everything. So we do tell them not take the yellow portion of the egg, take only the white portion. But I like Dr. Sahni to comment on that.
No, I think the recent concepts are very clear. As I said, dietary contributions hardly. So what we have, even textbook of Brownwald has written, the absorption of cholesterol from the diet is so heterogeneous, so complex, and it is genetically determined. I mean, if we all take one egg, full yolk of egg, I may increase 2 milligram, you may not increase at all, third person will increase 10 milligram. So that is the story. So ultimately, end of the day, for general public, one full egg is allowed. I mean, including yolk. There's not much a problem.
Not only the
general public.
Yeah, because I think this must be one of the burning questions in the mind of the audience here today. So thank you for the clarification.
Welcome, Dr. Dharmendra Jain. You'll be speaking on I hope the lipid guidelines which are given by the RSSDA recently, and this one. Dr. Dharmendra Jain is professor and HOD at the BHU Medical Center, Varanasi. So over to you, Dr. Dharmendra Jain, for the lipid guidelines of RSSDA.
Okay. Actually, I think Dr. Dharmendra Jain has an issue with this bandwidth. using the same mobile for sharing the slides and also talking. Meanwhile, while he is sharing the slides with our tech support, we think we can, Dr. Kabra, we think we can discuss something about the lipids to keep the clock ticking.
Yeah. I
yeah.
think lipids, as we all know, the big five of cardiovascular risk factors: diabetes, hypertension, smoking, family history of premature coronary artery disease, and hyperlipidemia is one of the big five risk factors for coronary artery disease or atherosclerotic vascular disease. And that way, but I may add another two risk factors to this big five, which includes having the South Asian race, belonging to South Asian race, or having the South Asian or Indian genetics, and also mild chronic kidney disease, which can lead to increase in the risk of coronary artery disease. That way. So for me, this becomes the big 7 risk factors. And even in India, the classical teaching has been, or the classical learning has been, that Indians have a coronary artery disease at much lower levels of LDL cholesterol, and the Indian dyslipidemia may be different from the dyslipidemia in the other countries of the world, especially the Caucasian races and the Far Eastern races that way. So probably maybe some research needs to be done on that. A lot of research has been going on in the past, and we have to look at some risk factors, especially in the lipids, which are unique to our population in that way. Lipoprotein little a has been identified as one of those risk factors, especially in our Indian population.
Yeah. That is very well said about the various risk factors, and which are also the environmental risk factors have to be taken care of with the incidence of the increasing incidence of the air pollution and the increasing incidence of the pulmonary diseases. They also contribute significantly to the enhanced risk of coronary artery disease, which is rather underappreciated, that these things can be lethal from the coronary artery disease point of view. And we have been very well said about the LP small a, and LP small a is now becoming one of the major focus of research these days into how to modify it, what drugs to use it, and I think that will be covered to a certain extent definitely by Dr. Dharmendra Jain. I expect to hear something new from him. And also there are, as you have already very rightly pointed out, the Indian dyslipidemia, which is basically I believe is basically a form of let's say metabolic syndrome, with a mild elevation of blood pressure, mild elevation of the glucose levels, and increase in triglycerides and altered body mass index. These things, they have been previously labeled as a deadly quartet, but now I think all of these somehow are connected to the metabolic syndrome as well, that that increases the risk levels, particularly of the Indian subcontinent, but the diet is much more rich in carbohydrates than in other forms. And India, I think, as a whole, consumption of the fruits and green vegetables, though it varies from parts of the country, is somewhat less as compared to the advanced countries as well. And these can also be contributed to our higher levels of coronary artery disease risk.
As rightly said, Dr. Sinha, I think air pollution for all these years has been overlooked as a risk factor for atherosclerotic vascular disease. It was supposed to be a risk factor more for chronic lung diseases and other this one. But I think probably it's high time we look at air pollution as the role of air pollution in increasing the risk of coronary artery disease and atherosclerotic vascular disease. And metabolic syndrome has been gaining importance for the last decade or two. And we have a lot of papers coming in towards the metabolic syndrome and that way. And probably, as you rightly said, there may be some type of a metabolic dyslipidemia which should be looking at, besides the LP-little-a, and that way to explain the much higher risk of coronary artery disease in our population.
Yeah, that's true. And what do you think about this management of triglycerides in the control of the coronary artery disease prevention?
So triglycerides traditionally have been considered to be a very minor risk factor for coronary artery disease, and an elevation of triglycerides above 1000 milligrams per deciliter was supposed to be treated immediately because it carries the risk of acute pancreatitis and not increase the risk of myocardial infarction or stroke. Whereas a triglyceride levels of 400 to 1000 are supposed to be in the danger zone and they need to be controlled. And less than 400, the recommendations were not to treat triglycerides at all, hypertriglyceridemia at all. But if you look at the research which has gone into the hypertriglyceridemia as a risk factor for coronary artery disease, many papers had said the triglycerides by themselves probably may not be a risk factor, which is important. It may be because of the low HDL cholesterol level, which is associated with hypertriglyceridemia, which may be contributing to the enhanced risk for coronary artery disease. So because of this controversial and all, triglycerides never get that importance. And the other point has been that we never had drugs which can control triglycerides. And after controlling triglycerides, which could show us a decrease in CAD risk, morbidity, and mortality, as like the statins and all. At the most of the statins, they reduce the triglyceride level by 15 to 20%. Like atorvastatin, rosuvastatin may reduce by 20 to 25%. But most of the statins, the decrease in LDL cholesterol was much more than the decrease in triglyceride level. So the last 2 decades have been the statin era, and maybe what is the residual risk? The different types of residual risk which we know. So that is the residual risk which is contributed by hypertriglyceridemia, in spite of patient being on optimal dose of statins. Probably it's a high time we look at that, and especially with relation to Indian dyslipidemia.
Very well
What
said.
are your thoughts on that, sir?
That's very well said, Dr. Kabra. That till date, and the role of triglycerides as a established risk factor has been under cloud, because when you take out the LDL equation, when you take out the HDL equation, triglycerides by itself has not been found to be of very much significance. But of late, I am finding there are some interesting papers that are coming in, which are looking at triglycerides in its own identity. And they're claiming that it may not be as benign between 200 to 400. It may not be as benign as we are trained to think. We are trained to think that triglyceride between 200 to 400, okay, ignore it. But it may not be that so easy. So it is perhaps coming of its own. Triglycerides is now, I would say, maturing a risk factor. Like
risk factor, yeah. But I think then again, probably we'll have to look at whether we are going to have fasting hypertriglyceridemia, or is it post-lunch hypertriglyceridemia we have to look at and all. So much work needs to be done. And I hope CSI takes up,
But people are taking an interest in it, active interest in looking into it.
And I hope as a treasurer of CSI, you're able to devote some funds to this work. And
certainly, you come up with a viable proposal, complete in its entirety, and would certainly, from the CSI, I will look into it.
Yeah, definitely, sir.
May I make one thing clear? As a treasurer, I am the signing authority.
Yeah, exactly. That's the reason I asked you. But as a treasurer, you are holding the cash back.
I am signing the cash back, but I have no independent authority to grant or refuse to grant. It is
wonderful. And I think we should thank Dr.
orders me, grant this, I'll grant that.
Great.
Wonderful. That also includes you. So
Wonderful. Thank you so much for that consideration, sir.
Yeah. Is Dr. Jain ready? The slides talks about. Have you received Dr. Jain's slide?
Yes, sir. I have now. I'll share.
Okay.
I can share.
And I think this bandwidth problem will go away. Dr. Jain can use his mobile for his. We can see his face, and also you can show his slides, and it will be a tango.
Join now.
Okay.
Sir.
Yeah. Yeah, the slides are there. And I think Dr. Jain can now proceed.
So, am I audible now?
Yeah. Perfectly audible.
Okay,
sir. Sir, whenever you want to go for next slide, kindly say next.
I will. So, we are going to discuss the novel oral antilipid mix with or without statins. Next slide. How I can remove this photo which is coming? Video.
Dr. Jain, stop sharing your video. Just go out and talk.
No, he already stopped, sir. He already stopped, and I also already stopped his video. Still, he's not getting.
No, I am getting the slide, and I want to remove this
Sir,
video.
sir, we are not getting your voice, sir. Probably we are not getting. We are not heard anything. I mean,
No,
hear anything.
I am getting your. Yeah, I am getting the slides, and I want to remove this video part. How can I remove that video picture in front of technical support team and remove?
Oh no! Just switch to no. There is a small PPT on top, right? Just click on it. You got it, sir?
Now it is removed.
Remove, no? Okay. Sir, but the problem is we are not hear anything, sir. Your voice is completely breaking.
Dr. Dharmendra, if you start talking, we will know, I think. Please say something.
No, he is joining.
No, I think it's disconnected. No, he's there. I think he's muted actually.
Yeah, Dr. Jain is muted.
And the tech support, unmute him.
The cardiovascular disease is major cause of morbidity and mortality. Can you hear me?
They're unable to hear you, sir, and it's showing us muted here. So maybe are you using two phones? Can tech support people have a kind look at that?
Sir, if you can move open area, no, maybe you'll get better network, sir. If you're in a closed area, so that's the reason you're not getting network. Kindly move open area to join again, sir.
But tech support, any idea like why it is showing as muted for his this one? Muted. Able to hear his voice. Yeah, now it's not muted.
Yeah, I have sent. I have unable.
Unmuted himself.
Yeah, I have opened the door. I am in the cath lab area. Okay.
Yeah.
So
audible now.
Okay. So there is a rapid increase in the CBD, and the total load of CAD is 31 million, and younger is more affected. And next slide, please. And these are the lipid-related factors, which is LDL, HDL, and triglyceride, and other inflammatory markers like HSCRP or major clotting factor of fibrinogen. These are the other risk factors which are associated with CVD risk. Next slide. And these are the behavioral and lifestyle risk factors like tobacco, dietary, and alcohol and physical activity. So we all know, we are all agree with this, that these are the modifiable cardiovascular risk factors which we can change in every patient. Next slide. These are the modifiable other risk factors like obesity, hypertension, diabetes. These all are interrelated and should be tackled along with the dyslipidemia. Next slide, please. These are the non-modifiable risk factors like menopausal status and in the loss of estrogen in this or surgical menopause. So that increases CVD risk, and gender also. CVD prevalence, incidence, mortality is higher for men than women. Next slide. So this dyslipidemia and CVD is associated. It is major independent risk factor for CAD, dyslipidemia, leading to development of ASCVD. It is responsible for around 4 million CVD-related deaths across the globe. And prevalence of dyslipidemia is in Indians is very high, with 79% subjects are having more than one lipid abnormality. So decreased SDL in 72%. Hypertriglycemia is in 29% and elevated LDL in 11%. So this dyslipidemia become a grave concern for lipid abnormality in CVD among Indians. Next slide, please. Next slide, please. So it is a very common condition in type 2 diabetes. So diabetic dyslipidemia, as I told, we will first discuss. It is having a special cluster of lipoprotein abnormality in which there is a triglyceride is increased, SDL is decreased, and LDL is small, dense LDL is high. So every 3 out of 4 diabetics suffer from the dyslipidemia. It's very high incidence. So it is a unique atherogenic dyslipidemia. It is characteristic which are frequently present in the South Asian with diabetes, including Indians. So preponderance of more atherogenic small dense LDL and increase in ApoB levels simultaneously. Next slide, please. So diabetic dyslipidemia patients are at heightened risk of CVD, and diabetes is a significant risk factor for ASCVD. LDL is number 1 predictor of ASCVD. In diabetics with dyslipidemia, 3 to 4 times high CV risk is noted as compared to dyslipidemia without diabetes. So it's very high risk factor, diabetic dyslipidemia. Next slide, please. So in Indian diabetics, it's association with other risk factors. So the high cholesterol, low SDL, high LDL, high triglyceride, high VLDL, normal lipid profile, and with abnormal lipid profile. 83% patients showed a presence of dyslipidemia, and higher level of TG, VLDL, LDL were observed. And disproportionate BMI and high waist, girth, and education level and financial background was found to be correlated with the dyslipidemia. Both triglyceride and VLDL are important marker of CVD. It should be screened in all diabetic patients. So diabetic dyslipidemia is very common in India. Next slide, please. 83%. So suboptimal adherence in the management of diabetic dyslipidemia. So onus comes to us physicians. As a physicians, we should see that it should be managed properly. And majority of ADA 2018 goals and recommendations for management of diabetes dyslipidemia were not met in most of the patients. So that is the main problem that we should tackle, and statins were not received by majority of patients in the recommended dose. So dose should also be proper. If we say moderate, it should be moderate. If we say it should be high intensity, then we should go with the high intensity. So the goal should be appropriate. The statin dose should be appropriate.
I think Dr. Jain again logged off. He'll join again. Till that time, we can continue the discussion.
I think Dr. Sinha, what's your opinion? The slide which is being projected, they show that 87.2%. It's a very troubling number and very alarming number.
Very alarming
And the
number.
percentage of patients not receiving statin or statin at the recommended dose. This is something which is really, I think, anguishing me.
So I think Dr. Kabra, if I may excuse, may be excused, part of the fault lies with us.
Is it?
Yes, sure. Because we have been unable to go out and have to disseminate the knowledge to our junior colleagues or in our community doctors that this is what should be done. We are pretty much, let's say, if I use a rather peculiar term, we are pregnant with knowledge, but we have not delivered that knowledge to the community.
No,
Right.
right. Well said, well said.
So,
and I think it's a duty of the bodies like CSI and other bodies and
distribute
each
the
and every
knowledge.
one of us, to
That is
disseminate
why
that knowledge.
we are finding these kinds of scenario. And one more scenario, what Dr. Jain has very rightly pointed out, that when you are talking about statins, we should specify how much and where. And it should be, please, I know we talk about low intensity, moderate intensity,
okay,
high
I can
intensity.
see the slides now.
And
Yeah,
Dharmendra has joined, I think.
Okay,
Yeah.
so
yeah, Jan. Okay,
please go to the next slide.
carry on.
Yeah, where we left, we are starting. So
Yeah,
please
please.
go to the next slide. So in a nutshell, early diagnosis and treatment of diabetic dyslipidemia are the essential, and it can reduce the morbidity and mortality due to the disease, very common and poorly controlled. And next slide. So we are going to discuss some slides for management of diabetic dyslipidemia, what the guidelines says. Next slide. So RSDI 22 recommended early diagnosis of dyslipidemia. In diabetes, dyslipidemia should be assessed at the diagnosis and annually thereafter. So annually, that is from age of 12 we have diabetes, inherent diabetes, and screening of dyslipidemia periodically in obese children, family history of diabetes, and those who from a predisposed race, ethnicity like Asian, American, Indian, etc. So we can also go for the ApoB level. It's a valuable for assessment of risk in individual with LDL cholesterol measurement, underestimate the burden of CVD. We can go for the ApoB level. And fasting plus non-fasting lipid profiles are important for managing Indian patients with dyslipidemia, considering possible genetic influence of Indian ethnicity on CVD. Q-risk3 score exemplifies as the current most accurate CVD screening tool available for Indian population. Next slide, please. Okay, what the RSDDI says that a comprehensive strategy is essential in managing the dyslipidemia, so as to regulate lipid level and manage the metabolic deviations and modify risk factors. So LDL is a primary target, and non-HDL cholesterol, HDL cholesterol, and ApoB as secondary targets. Next slide, please. Okay, so ASCVD is categories and treatment goals for dyslipidemia in patients. By definition, LDL cholesterol in high-risk patients, diabetes with no other risk factors, we can go with the less than 100 target. And if it is very high risk, then it should be less than 70. Very high risk means by definition diabetes with more than one risk factors, major risk factor for ASCVD. When the diabetes with established clinical ASCVD, so then it should be the less than 55. High risk less than 100 without risk factor diabetes. Very high risk if it is one risk factor less than 70, and extreme risk when the established ASCVD. So non-HDL goal is less than 130 in high risk, less than 100 very high, and less than 80 for extreme risk where ASCVD is there. ApoB level is less than 90, less than 80, and less than 70, and triglyceride is less than 150 in all. So high risk patient necessitate management comparable to that for the secondary prevention of cardiovascular disease. Next slide, please. So there is a step-by-step strategy for Indian patient with diabetic dyslipidemia. So we can stratify the risk for ASCVD and then initiate and escalate the lipid lowering agents. So what should be the for LDL cholesterol? We can go with the statin moderate intensity or high intensity. So the doses for moderate intensity is atorvastatin 10 to 20, rojuva 5 to 10, simba 20 to 40, pitava 2 to 4, etorva 40 to 80. Then going for high intensity, that etorva is 40 to 80 and rojuva is 20 to 40. And we can add ezetimibe when goal not met with high intensity statins, and we can add the PCSK9 inhibitors if goal is not met even after that. In established ASCVD patients. For triglyceride, we can use statins. We can also use the other agents available like fibrates, saroglitazole, or omega-3 fatty acids. At moderate or high intensity CVD risk can be initiated when triglyceride is more than 200. So if in high risk cases, we can go with this, and otherwise we have the statins, they can take care of triglyceride also. So like that, we can use that various scores and decide the risk, and accordingly the targets are defined. And in LDL goal should be moderate risk patients, high risk patient, and very high risk patient. Accordingly, we have already discussed in the previous slides. It should be target goal should be
Dharmendra, we are not able to, I think your voice is not clear. You're not muted, but we are unable to hear you.
okay.
Better.
Can you hear me now?
Yeah, we are able to hear now.
Okay, can you go for the next slide, please? Tech support. Okay, okay, perfect. So for treatment,
We heard
based on the
your
risk for primary prevention. Can you hear me?
yes, we are able to hear it. In between, again, there's a break for
Okay.
treatment. After that, there is some break, and again, we are able to hear it now.
Okay, primary prevention patient without ASCVD. ASCVD is not there. Diabetic patients 40 to 75 we are without ASCVD. So we can use moderate intensity plus lifestyle. Lifestyle should be there in all the cases. And moderate intensity is enough for diabetic patients without ASCVD for primary prevention. And if it is 20 to 39 year and with some additional ASCVD risk factor, it may be responsible to initiate therapy in addition, statin therapy with lifestyle. And diabetic patient at high risk, especially those with the multiple ASCVD risk factor or aged patient 50 to 70 year, then reasonable to use high intensity statins. These are the really at high risk. And adult with diabetes and 10 years ASCVD risk more than 20%, then it may be reasonable to add ezetimibe to maximally tolerated statins to reduce the LDL by more than 50%. So target is here now to more than 50% decrease in the baseline level of LDL along with the ezetimibe with the statins. Next slide, please. So,
Hello, Dr. Jain.
Yeah. Can you hear me, Preeti?
We are able to hear you, Dr. Jain.
Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Okay. So for secondary prevention, now the patient is having ASCVD established. So if it is diabetic patient with ASCVD, all ages should have a high statin, and it should be added to lifestyle. And diabetic patient with ASCVD considered very high risk using a specific criteria. If LDL cholesterol is more than 70 on maximally tolerated statin, then consider adding additional LDL lowering therapy like ezetimibe or PCSK9. Patient who do not tolerate intended intensity, then maximum tolerated statin dose should be used. So now the role comes for ezetimibe or PCSK9 when there is if LDL is more than 70 in established ASCVD. Next slide, please. Adult diabetes and baseline LDL and on statin therapy for primary prevention, then there is a algorithm they can go with the risk for more than use start with the intensity statin, and if the risk is more than 20%, then we can add on the so this is the same algorithm, I think, which case is almost. Next slide, please. Then cornerstone is the statin therapy. Next slide. So statins are the mainstay therapy for diabetic dyslipidemia. It inhibits the reductase enzyme that is originally utilized for de novo cholesterol synthesis. So decreases the plasma concentration of LDL and also have the benefits, improving the MCL, stabilize the plaque, and subsequent reduction in the platelet aggregation. So RSSDI 22 guidelines says that unless contraindicated, first line cholesterol lowering include the use of moderate to high intensity statin depending on the situation. Next slide, please. So effect of a statin on LDL reduction in diabetic patients. So the different statins have been compared, Rosuva versus Atorva in CORAL and Andromeda study, and they have clearly shown the benefit of Rosuva over the Atorva. Next slide, please. Similarly, the Uranus study and Mercury 1, they also shows the Rosuva showing the greater reduction of LDL as compared to Atorva. Next slide, please. and effect of Rosuva in Indian diabetic patients with newly diagnosed dyslipidemia. So Rosuva safety and beneficially alters the entire spectrum of lipoprotein in Indian diabetic dyslipidemia patients. So it is showing that after Rosuva there is 25% reduction in LDL cholesterol of less than 100 target, and 61% of patients had achieved the target of LDL according to NCP ATP3 guideline, and 67% achieved the SDL also 40 to 60 milligram, and 63% achieved the total cholesterol target and 50% triglyceride target, and adverse events reported were generally mild. So it's well tolerable. Next slide. So, Rosuva versus Atorva in glycemic control and diabetic dyslipidemia. So, Rosuva can be preferred choice in comparison to Atorva in treatment of diabetic dyslipidemia due to less variation in blood sugar parameters and effective control on lipid profile and pleiotropic effect and less microsomal interactions. So, there is a rise in the FBS, PPVG, EAG significantly with the atorvastatin compared to Rosuva, with a significant increase only in fasting sugar level at 24 weeks. Next slide, please. So, risk of cardiovascular event in diabetic patients with dyslipidemia. So, guideline recommendation is there that statins are beneficial as a primary or secondary prevention strategy to reduce the risk of CV event in CVD or multiple CVD risk factors, especially in those with diabetes. So, 22% reduction in CV events, including ischemic stroke and diabetics with the use of statins, and 37% reduction of CV events, including ischemic stroke in diabetic with the use of statins. So, heart protection study and collaborative atorvastatin diabetes study shows that clear-cut benefit of cardiovascular events. Next slide, please. So, there is a need for add-on therapy along with the use of statin in certain CV risk persists despite ongoing statin therapy. This indicates the need for additional therapy in patient of CVD. And high lipid levels are causally related to cardiovascular disease. So drug therapy targeting this lipid abnormality could help further to reduce the CVD risk in people with diabetes. So there is a residual risk even with the statins, and addition of fibrates could be another beneficial treatment option in such cases. So fenofibrate has such shown to reduce the CVD in diabetics with elevated triglyceride and low SDL cholesterol levels. So in diabetic dyslipidemia, it can be helpful. Fibrates. Next slide, please. Okay. So effect of fenofibrate as an add-on therapy in diabetic dyslipidemia, a Korean study. So it shows that 27% reduction in the risk of CVD in diabetics with elevated triglyceride and low SDL cholesterol with fenofibrate plus statin as compared to fenofibrate alone. So addition of these two drugs can help in further reducing the triglyceride and increasing the LDL. Next slide, please. So the effect of fenofibrate is there in a Korean study, and incidence rate of fenofibrate statin combination group were lower with the respect of all-cause mortality, CVD mortality, non-fatal MI, CHF, and major CSD as compared to placebo and post-trial follow-up. And evidence of this legacy effect of fenofibrate statin combination on all-cause mortality was observed in diabetic dyslipidemia. Next slide, please. So, fenofibrate as a add-on statin in adult with metabolic syndrome in real-world setting. So, there is a 26% reduction in the risk of major CV event with the fenofibrate as add-on to statin than statin treatment alone. So, combination is good in the metabolic syndrome also. Next slide, please. So, another option is the omega-3 fatty acid, which can be added on to statins. So they have offering the additional benefit when administered as an add-on due to its diverse mode of action, and it lacks clinically significant drug interaction with the statin and does not have a deleterious effect on liver function. So it's a safe to use this omega-3 in diabetic dyslipidemia as an add-on therapy. Omega-3 are fatty acids are indicated as an add-on to reduce the triglyceride level if the patient is having more than 500 hypertriglyceridemia. And the CCS guideline 2221, this says that use of these IP to reduce the CV event risk in patient with ASCVD or those with diabetes and more than one CVD with an elevated fasting triglyceride in millimole, it is 1.5 to 5.6, and despite treatment with maximally tolerated statins. So if the triglyceride is really high in the ASCVD patients or diabetes with more than one CVD risk factor patients, so these patients, if they are having really high triglyceride, we can add on this omega-3. Next slide, please. Effect of omega-3 as an add-on to statin in the management of diabetic dyslipidemia. So data from the reduced trial shows that in 8,000 patients, they have added on these in 150 to 499 persistent hypertriglyceridemia. And then they found that 25% relative risk reduction, a significant p-value less than 0.001 in MACE with these EPA at a higher dose, 2 gram BD as compared to placebo. Similarly, data from the anchor study also shows significant favorable effect on lipid parameter with 4 gram of IP with no deterioration of glucose parameter in diabetic dyslipidemia. Next slide, please. So statins are the cornerstone of dyslipidemia and are generally safe. A considerable proportion of a statin treated patient may encounter statin intolerance. This intolerance to statin or inability to reach that LDL target and restrict the use of intensive statin therapy in such individuals. What about the management of diabetic dyslipidemia, which are intolerant to statin? Now comes the role of novel agents. Next slide, please. So this is the bempedoic acid, safe, effective oral therapeutic option for lipid lowering in patients who are intolerant to statins. So there is a data from the CLEAR study. There is a reduction by bempedoic acid compared to placebo if there is a hypercholesterolemia and statin intolerance. So then LDL cholesterol can be reduced by bempedoic acid minus 21, non-SDL minus 17, total cholesterol minus 14, ApoB minus 15, and HSCRP 24. Then data from the meta-analysis also shows that bempedoic acid compared to placebo was associated with the 25% reduction, risk reduction of CV outcome, reduction in LDL cholesterol, and 35% reduction, risk reduction in new onset worsening diabetes. So it's helpful in preventing the cardiovascular events along with the reduction in LDL cholesterol, just like statins. If the statins are intolerant, then. So it's very clear message that bempedoic acid is an add-on therapy or is you can be used as a option in statin intolerant patients. Next slide, please. So please. So also guidelines says that considering predictable risk level and baseline LDL cholesterol and keeping their health condition and risk of drug interactions should be kept in mind. So people with age more than 75, if at high risk or above, statin therapy may be considered for primary prevention. In cases substantial renal impairment should be initiated at a low cholesterol. Guideline also says that if it is more than 75-year diabetic patient on a statin therapy, it's reasonable to continue statin. If it is maybe reasonable to initiate a statin after a discussion with the potential benefit and risk. So we should discuss it with the family and patients regarding. So it is strongly correlated with the diabetic nephropathy also, this diabetic dyslipidemia. So these are all correlated CKD, cardiovascular disease, and dyslipidemia. Next slide, please. So the treatment of dyslipidemia with the statin may delay the progression of diabetic nephropathy, reduce the cardiovascular risk, and early identification and aggressive treatment if needed is important in diabetic patients without contraindication or end-stage renal disease. So statin has not been associated with the decline in renal function, and dose adjustment, keeping in mind the eGFR, may be judicious in those with the severe kidney dysfunction on intensive statin therapy. Statin not only decrease the CV event, but also delay the progression of nephropathy. So we should use the statins in renal patients. Only caution is required in severe renal dysfunction to follow the eGFR. This need a special next slide, please. in CAD patients. Next slide, please. What the guideline says. So LAI 2020 guidelines, CAD is designated if ACVD layer, then extreme risk group is divided into two categories. Category A, with more than one feature of high risk. Category B, where there is more than one feature of high risk group, or current ACS within 1 year, despite LDL cholesterol less than 50 or polyvascular disease. So these are the category A and category B of Lipid Association of India 2020 guidelines. Next slide, please. Next slide, please. So lipid management is an important part for secondary prevention. If already established ASCVD is there, so CAD or any form of AS, 50% reduction LDL level, and LDL level less than 55 milligram absolute value. So target LDL goal is less than 40. It's much more stringent for the patient with the repeat CVD event within targeted to this is actually ESC guidelines. Next slide, please. So already established
Hey, voice not clear.
Nine inhibitor. So next slide, please. Slide. So ACC 18 guideline on secondary prevention with clinical ASCVD. So they have they say that we should follow the healthy lifestyle of patients so that we can see ASCVD not at high risk or very high risk. High intensity less than 75 years, and this class 1 then so this is for less than
Dr. Jain, you are not audible. Take support, can you see into it? Dr. Jain is not audible at all.
Can you hear me now?
Yeah. Dr. Jain, we are running short of time.
Okay, so can we go to the next slide, please? I will summarize, sir. So these are the guidelines for not at very high risk. We can discuss. We have already discussed that the moderate intensity statin can be started in the very elderly group. Otherwise, we should start with the high intensity statin in the less than 75-year group. Please go for the next slide. So LDL lowering effect with the statin provide benefit in terms of CV events. So 21% CVD event with every 1 millimole reduction in the LDL cholesterol, and 27% reduction in coronary event, 15% reduction in stroke, and 24% increase for the coronary revascularization. So these are the benefits with the LDL cholesterol. Next slide, please. Dyslipidemia management data from the POLA study, and then 14 Department of Cardiology from 12 different hospitals participated in the study, and the 94% were prescribed statin and 68% hospitalized for ACS. And post-discharge period, intensity of lipid lowering was increased in 17%, decreased in 11%, did not change in 71%. So this is the percentage of statin, 94%, and was statin on the patient hospitalized 60%, and patient-related factor related to control of hospitalization due to CAD. This is the in summary, the stringent control is important in patient with diabetes and CAD and AD for prevention of reverse.
Yeah. Thank you, Dr. Jain, for an excellent discussion on diabetic dyslipidemia. To all our listeners, today we are discussing use of novel oral anticoagulant agents with or without statins in the clinical scenario. One part of the clinical scenario in that is diabetic dyslipidemia has been adequately taken care of. But as Dr. Jain has said very aptly, that 1 millimole, that is approximately 40 milligram per deciliter, with which we are more familiar, reduction in the LDL will lead to approximately 21% reduction in CVD deaths, 20 MI 27%, and reduction in the stroke 15%, and CABG by another 11%. That's okay, but that still needs a very clearly unmet need of further risk reduction. The risk is not becoming zero. We all know that there is no lower limit of LDL, which is not.
I think that was.
Sorry, Dr. Jain, you were saying something? Dr. Jain, are you saying something?
Yeah, I think. Yeah, that was the summary slide. After that,
we all got it. We all got it.
Okay.
Thing is this, but what is the lower limit of LDL cholesterol? Well, I think this part will be taken care of by Dr. Kabra. Will you talk about something about what should be the lower level of cholesterol and how low can you go?
Thank you, Dr. Sinha. And I think most of the guidelines, the European, the American, as well as the Indian, and the less quoted like the Canadian and the Japanese, Taiwanese and all, they've been converging towards the opinion that the lower the LDL cholesterol, the better and all. For the first time, I think one of the Indian guidelines, they had recommended a LDL cholesterol level of 30 milligrams per deciliter. Probably we may not personally agree, but I do agree with the European Society recommendations of 55 milligrams per deciliter. And today in Dr. Jain's presentation, we have seen that even the RSSDI, they're also recommending 55 milligrams per deciliter as the lowest level of LDL cholesterol. So we have been the traditional teaching and the traditional learning, we have been taught that LDL is the bad cholesterol, and it is the most important risk factor for development of atherosclerosis and all. And the other points I think which Dr. Jain has brought out, addition of drugs. If the LDL cholesterol level is not controlled with a single statin drug, we start with the moderate intensity drug. We don't start with the low intensity statin. We start with moderate intensity statin and we go up to high intensity statin. Still, if it is not controlled, we can bring down the LDL cholesterol level, either fibrates or by ezetimibe, PCSK9 inhibitors and all. And for the triglycerides, which we were asking initially, he has already told us about the fibrates and omega-3 fatty acids. And he did touch upon icosapentaethyl also regarding the triglycerides and all. For me, I have been a proponent of LDL, the lower the LDL, the better. And for me, for primary prevention, probably 70 milligrams LDL is the cutoff point where primary prevention should kick in. And probably it will go a long way in preventing the risk of CAD in Indian population that way. As all of us know, we are very high risk group for development of CAD, and primary prevention for us probably should start at LDL level of 70 milligrams per deciliter.
Yeah, very well said, Dr. Kabra. But here comes a question, which I was going through the literature. What is exactly meant by a low intensity statin, a moderate intensity statin, and high intensity statin? We tend to speak of them like they are something in the scripture. They tend to roll up our tongues that, oh, give a low intensity statin, give a moderate intensity statin. What exactly do we mean? In this context, just let me finish.
Dr. Sinha, actually, all this thing had started in 2014. I remember the 2014 ASCVD risk score had come in and all. Before that, we never believed in something called as low intensity, moderate intensity, high intensity statin. So this is all after 2014. And the guidelines which they have recommended, the low intensity statin will be either a 10 mg of atorvastatin, and a 10 mg of rosuvastatin is a moderate intensity statin, or a 20 mg of atorvastatin. And a 40 mg of atorvastatin or a 20 mg of rosuvastatin is considered as a high intensity statin. So these are the recommendations which have been given by the guidelines, and it's all started with the ACVD guidelines of 2014.
That is one message should go clearly to our audience, that when we are talking about low intensity statin, we are talking about 10 milligram atorvastatin. When we are talking about moderate intensity statin, we are talking about 20 milligram of atorvastatin or 10 milligram of rosuvastatin. And when we are talking about high intensity statin, we are talking about 40 milligram of atorvastatin or 20 milligram of rosuvastatin. In this context, do you think, just like the Japanese guideline, do you have a higher ceiling of how much statin should we give? The Japanese have a ceiling. They will give 20 milligram of rosuvastatin is the ceiling dose. Do you agree with that?
We do have 40 mg, which has been available for a long time. And we do have some experience with 40 mg of rosuvastatin in patients with acute coronary syndrome. There, we know that the rosuvastatin may have an anti-inflammatory effect, and there may be some pleiotropic effects of statins, where probably 40 mg of atorvastatin is going to help the patient. And I think it's not the ceiling of the dose, probably we have to individualize, and it has to depend on vary from patient to patient. If the patient is able to tolerate 40 mg of rosuvastatin, and if that is able to bring out the LDL cholesterol to less than 55, I think there's no reason not to prescribe 40 mg of rosuvastatin. And for the last almost from 2007, we have been using 80 mg of atorvastatin in patients with acute coronary syndrome. So I am all out for high intensity statins, especially in acute coronary syndrome, maybe for a year or two, and then depending upon whether the patient is tolerating or not, and whether how is the LDL cholesterol behaving, we may be able to de-escalate, like the DAPT de-escalation, we may be able to de-escalate even the statin dose. So probably we may be talking about that.
Yeah, very well said, Dr. Kabra. And that's the one point that has been made clear across the board. But what about those patients who cannot, or who have received maximally tolerated dose of statin, have not gone to a goal? Or even if they have gone to a goal, would you like to further reduce the LDL cholesterol by using the novel agents, the novel agents that are on board today, and many of which are right now available